Once again, my name is Dasha Ocheret, and I was born in the Russian Federation, and now I live in Lithuania, and I work for Eurasian Harm Reduction Network, which covers a lot of countries from Central Europe, Eastern Europe, and Central Asia. And I was asked to speak a little bit here about the current state of quality and access to harm reduction services. But in the beginning, I would just like to say that when I will be speaking about harm reduction, I will not be speaking about the impact of harm reduction just on HIV prevention, because harm reduction is much, much more. It has enormous impact, or it may have enormous impact on access and quality and outcomes of HIV treatment, but not just on HIV treatment, not just on TB, hepatitis C treatment, not just on overdose mortality, but also harm reduction is about safety and well-being of communities, not just communities of people who use drugs, but their family, their neighbors. And I think that we were missing this information in all the advocacy statements that we were delivering. So, well, harm reduction in our region started long ago. I think in a couple of years we'll be able to say that it's already 20 years of harm reduction. Does it work in our region? Do we have enough evidence to say that yes, in such countries as the Russian Federation or Kazakhstan or Azerbaijan or Armenia, Lithuania, did we receive impact? Can we prove that we have impact on HIV epidemics, on the trends? In some places, yes. In some places, no. And I would say that one of the issues of advocating for harm reduction in the Russian Federation several years ago was that we didn't have local evidence, local data showing that in all the places where we had needle and syringe programs, we could see decline of the HIV incidence among people who inject drugs. And actually the slide that Michel has shown in his presentation, that it is very difficult to achieve this epidemiological impact just with having limited needle and syringe programs. You need to have all the three interventions. You need to have methadone, you need to have needles and syringes, and you need to have antiretroviral treatment. And there are not a lot of places in the region where we have good access to high quality services for three. So when I talk about the quality of these services, what do I actually mean? If we look at the access among women who inject drugs to harm reduction services, we will see that in any city we choose, there are less women who are clients of harm reduction programs and who are clients of methadone or buprenorphine programs than men. And very often we'll get responses from people that, well, there are fewer numbers of women who inject drugs in the region than men, but in fact we will see that there is disproportionately low number of women among clients of needle and syringe and methadone programs. And this is an issue of quality. There are enormous barriers to receive methadone programs, to receive methadone. And I would not say that there are some very specific gender barriers, but programs are not attractive for women. They cannot get care they need. They do not get access to sexual and reproductive services. They may not have money to travel to methadone sites. There are a lot of issues we see. But the most important thing is that when we start providing gender-sensitive harm reduction services, we see that the proportion of women among clients starts to increase, and in some places it can reach 50% among all clients just in 1 year. Talking about methadone programs, I see a lot of people who are currently on methadone in different places of the region, and I also talk to people who were clients of methadone programs and who decided to stop, who decided to quit. And one of the main barriers, one of the main issues with quality that they name is that there is no option for methadone take-home doses. What does it mean in reality? In reality, it means that if you are on methadone for 1 year, 2 years, 5 years, or 10 years, you will have to come to the clinic every day to receive your dose of methadone, which means that your family life, your professional life, even going for holidays to another country would be very problematic because you become dependent on the methadone side. And a lot of people who start methadone treatment interrupted after several months or several years of treatment, and we often see that they return to injecting drug use. We also see high mortality in our region due to overdose, due to opiate overdose, and due to tuberculosis. And I would say that we are still not paying enough attention to this. We can prevent overdose deaths through peer distribution of naloxone. We had good and effective naloxone distribution programs that were supported by the Open Society foundations. Now, we do not see continuation of these programs, even though the Global Fund agrees to pay for naloxone distribution. I could continue this list of issues of harm reduction related to quality of harm reduction programs, but maybe now I'll focus on the factors why we still do not see improvement on the regional level. Because, of course, I could name here 10 or 20 harm reduction programs in different cities from different countries where most of these issues were resolved. But in general, why do we not see real improvement of quality? I think we can speak about 3 major groups of factors. Like the first is, of course, related to funding. As Michel mentioned in his presentation, and VRL will speak more about it, we are dependent on the Global Fund, and when the Global Fund leaves the country, we immediately see closing down of large number of harm reduction sites. We have seen it in the Russian Federation, and we may see it in other countries of the region because we develop from low-income and middle-income countries to high-income countries. But even when we have funding from the Global Fund, how much work does it allow us to do? In general, for a 500,000 to 1 million population city in the region, you will have 4 outreach workers. What does it mean in practice? In practice, it will mean that one outreach worker will need to have at least 1,500 clients to reach 60% coverage. How can we expect quality of outreach work? How can we expect quality of counseling if the number of clients is so high that you probably may spend, 5 minutes per year, 20 minutes per year per each client? It's simple mathematics. It's just simple math. And when we talk about funding, we need to think in these mathematical terms. We need to calculate how much we invest and what kind of quality and coverage we can really expect from these investments. And the other issue is legislation in the region, which really makes our harm reduction programs, especially methadone programs, very expensive. For instance, in Georgia, which is my best beloved example here, according to the law, methadone programs are organized in such a way that they become extremely costly. You must have at least 3 medical doctors to work in each methadone clinic, even if you have 50 clients. People need to come to methadone daily. And when you calculate unit cost, you will see that it's very high. But it's not about efficiency, it's about legal framework. We need to change legal framework to get better quality, but also to get more cost efficiency from our programs. And to finish my presentation here, I would say that, well, I'm a little bit pessimistic these days, frankly speaking. And there is just one, because of political epidemiology, as Michelle named it, and also because I work in this area for, I think, 16 years, and there were times when we saw improvements, and today we don't see a lot of improvements. But there is one very important thing happening in the region today, and I'm proud of this because I'm part of this, and this is not typical of a lot of other places of the world. This is involvement of leaders of the community of people who use drugs into advocacy, into drug policy reform, into documenting human rights abuses, and into improving quality of harm reduction services. We see the network of Eurasian people who inject drugs, who has quite large membership at the moment, who are very active. Who are very active not because they receive some financial support from international donors, but because they understand that no one will take care about their lives and health and rights if they do not start advocating from the ground level themselves. And finally, I would say that we need to support them not just morally, as we say it in Russian, but we have to support them financially as well. And we need to make sure that significant part of our global fund, OPEPFAR, or national government's money is spent for the support of community system strengthening. And here I mean not just provision of services by people who use drugs, but their involvement in policy decisions, in program implementation, and in keeping ourselves as service providers and our governments accountable. Thank you.